The current models that we use in our mental health systems that structure services, they're finished. If you want to follow where the scientific evidence is telling us, it tells us that we've been researching, looking for the biological basis or even the psychological basis of the conditions. We haven't found anything. If you look at the levels of disability associated with people who come and get diagnosed with a mental health problem, they're not decreasing, unlike in other conditions, they're increasing. If you look at the outcomes from real-life mental health services, they seem to be much better at creating long-term patients than they are at alleviating people's distress in the long term. I think one of the basic problems that we have is that we've structured a lot of our services around a concept that is actually unsustainable and factually incorrect. So we talk as if we have psychiatric diagnosis, as if psychiatric diagnosis exists as a real scientifically already established phenomena. But the thing about diagnostic systems is that it's a way of classifying that's meant to have explanations. So when we classify somebody with, say, diabetes, we're talking about an abnormality of the sugar metabolism. When we classify somebody with asthma, we're talking about the bronchi in the chest that are closing off and making it hard to breathe out. So our classifications in the rest of medicine uses a diagnostic structure. And diagnosis is a way of classifying by cause. But in psychiatry, our classifications are not diagnostic because they have no explanatory value. All they are is describing people's presentation. Calling it a diagnosis is a bit like saying that the pain in my head is caused by a headache. So saying that your low mood is caused by depression is a similar fallacy. And so the first thing we need to do is to move beyond and out of a system that is clearly failed. It's failed at every level you think about. The drugs that we use appear to have some short-term benefits, but in the long term, all the research seems to tell us that those benefits don't last. In fact, people who stay long-term on medications and long-term in treatment, for many of them, the outcomes get worse than if they either never had the medication or if they recovered using more psychological approaches. We've developed this belief, which actually defies the evidence, that one of our major problems is stigma. And by stigma, we mean the idea that we don't accept that what we're calling mental health conditions are diseases, illnesses like any other illness. But as I've said, what we have is actually a descriptive classification, not a disease-based classification. And if you look at the research on stigma, what you find is that stigma is most associated in the public's mind with the idea that mental illnesses are illnesses like any other. And in the public's mind, that's associated with the idea that people are more predictable. They could be more dangerous because these things are happening without any sign. They're coming from their biology. And a desire for greater social distance. Whereas psychosocial explanations are associated in research, in the public's mind, with a sense of empathy, a sense of understanding, and a desire to be more helpful and less fear. So actually, the things that stigmatize are also the same things that are seen to be responsible for some of the poor outcomes that we are experiencing in our mental health services. There is another point which I think is useful to understand, which is also driving an increasing number of people into believing that either they or someone they're looking after or they know might be suffering from a mental health condition that requires some specialist expertise. So we've had a lot of, in connection with anti-stigma campaigns, we've had also in a lot of countries public health and media coverage with the idea that we have lots of mental health and mental disorders and mental illness out there that is not being diagnosed and that is not being spoken about, and that we need to get better at recognizing, and we really need to get better at early intervention. The problem is when we have these coverages in the media, they talk about mental health as if it's a thing that we already know about. But what do we mean? When you listen on the radio, on the television, by somebody talking about 1 in 4 people will have a mental health disorder. The thing it can do is that people can start looking inside themselves. And one of the consequences, I think, is many people, and sometimes populations and the culture as a whole, starts becoming afraid of emotional experiences, starts becoming afraid of the intensity of being human, of experiencing intense states of emotion, of distress, of confusion, and all of these things, and seeing that more in the realm of something going wrong, something broken, something abnormal, as opposed to perhaps seeing it more in the realm of the types of things that I define as ordinary or understandable. So we've widened the pool of types of experiences that people start to question in themselves or in their children, that they think might be signs that if they don't go and seek help for them and get professional input and get some expert advice or treatment, that these might lead to something a lot worse in the long term. There's a few simple ideas that could start us on that journey towards a mental health system that is more geared towards a view of the human as essentially resilient, as essentially capable, as creative, and as the experiences that they have as being within the realm of understandable, ordinary, and even when they're not in the realm of understandable or ordinary, they are still things that we can have models for that will help people make sense and make changes in their life. We need to get rid of administrative systems and treatment pathways that use the idea of diagnosis, because like I say, that's finished. There's no repairing that system. It's creaking, it's falling apart because it doesn't have the evidence either clinically or scientifically to support it. So whether it takes 5 years, 10 years, 50 years, at some point that is finished. So we might as well start now by stopping the perverse incentives that come when we structure our administrative systems around this false idea that a diagnosis tells us anything useful. There's much simpler ways that you can use administrative ways to keep track of something. So there has been, I know for example of some work with Professor Kinderman in Liverpool, who's developed a very simple system where you classify by problem description. And you literally take the number of problems that people describe as the reason that came to services, and you just use that. So it could be hearing voices, and that's the problem you've come about. It could be low mood, and that's the problem you've come about. It could be self-harm, and that's a problem you've come about. It could be worried about my children's behaviour. So there's a number of simple things that you can develop an administrative system around that. So if you're going to eliminate diagnostic language, you can also eliminate all other medical language. So instead of talking about symptoms, you talk about behaviours, experiences, and use more ordinary, everyday languages like that. You could have simple things like an assumption that all people are trying to do the best that they can in various moments of their life. And that can be your starting point, because there would be some shift needed to decenter expert-based descriptions of problems. And you want to be able to move people away from, because that can fall into all sorts of judgments which can make situations by accident worse. A really useful model is the feedback-informed treatment model, where the principles are that you are involved in a certain intervention, and if things are not improving, you're monitoring whether things are improving or not from the person's you're seeing point of view, and if things are not improving, you have a discussion with the person, with the team, and you might choose to change worker, or you might choose to bring other people in, family members, or you might choose to change the direction of your therapy. But you have an active idea that when things are not going well, it isn't necessarily because the client is a bad client, but maybe you haven't got quite the right fit of therapy for people. And I think moving towards a much more community-centered approach, which involves an understanding of people's context, is another really useful thing that services can develop. So there are quite a few things already well developed that we could push services towards encompassing. In 2012, I moved to the team that I'm currently with, and we started instituting a project to develop a systemic version of a feedback-informed model. And we developed various things along the way. And what we found was, for example, I inherited over 100 cases when I first started, which was not untypical for consultant psychiatrists. Because what happens in more medical model-based working is you see patients, you make a diagnosis, maybe make more than one diagnosis, you put them on a treatment pathway, and if that includes medication, for example, then it's up to the psychiatrist to continue monitoring them. And what happens once you go down the route of medication, it seems, and the route of diagnosis, you've cultured patients into an idea that this is a long-term problem, and so your caseload just expands and expands. So we brought in this new model, which was a more systemic. So I was seeing patients out of this big caseload, and discovering that even though they've been in services for many years, they've been on medication for many years, things had maybe got better for a while, but things were back to. And so they were just going through the motions, you know, coming up for appointments every 3 to 6 months and nothing really going on. So using this model of using team supervision, getting away from diagnostic thinking about what is going on in the families, who can support what are the goals, what are they trying to change, what are the things that are important to them. If medication's not helping, well, why don't we try reducing? Sometimes actually medication in the long term can create more problems. People who maybe are now quite anxious, it could be side effects of, you know, stimulants will make you anxious. Stimulants will, so, you know, understanding this and understanding the problems with withdrawal. And after about 2 years, we looked at our caseload and we discovered that we'd halved the number of patients who'd been with the service, open to our service for more than 2 years. Now that I'm established in that team, I have a much smaller caseload, which is just my own to manage, and I have much more time to do consultations, and we do things like one-session clinics. We work with other services because we often find families who get labelled as multi-problem. They collect different professionals, so we have consultations with professionals, and most of those consultation meetings involves trying to see who of the system that the family could sack, because the more people you have, the more you undermine. You give the message that the problem must be really serious, but you also undermine people's own resources because they become more and more reliant that somebody out there is going to find. So this kind of systemic thinking, turning what are been previously conceived of as medical diagnostic problems into more human, relational, and things that happen in people's lives, not because it's anybody's fault, and thinking about what resources, what strengths, and what things that people are already being able to do. And we kind of managed to get some of that culture established, and it had quite a big effect in terms of what was happening in our team. Our throughput improved. We still don't have a waiting list in our team. I know in neighbouring teams there are people who are on waiting lists for months, and I've heard in another city there's people on waiting lists for over a year just to start. We don't have any of those problems because people come, they're with us for a while, things improve, and we discharge them.